talk today about what clinicians should know about mammography. The lecture is designed and targeted on the primary and radiology. So at the end of this lecture, we should highlight 3 main points. When to do mammogram, screening mammogram at the first. What's the new updates in the breast screening recommendation? How we do mammogram, and what can be seen in the mammogram, and what the new updates in the breast imaging. At the beginning, in 2003, the American Cancer Society recommended annual mammogram for all women starting from age 40, when continuing as long as the woman remains healthy, as well as the same group recommend clinical breast examination periodically between the age of 20s to 30s, and every year for the woman at the age of 40 and upwards. The new recommendation just published 1 week ago in the Journal of American Medical Association changed all of that and come at a time of growing awareness about the potential downside of screening and harm of over-diagnosis. The American Cancer Society recommends that women with an average risk of breast cancer with no family history or genetic predisposition should undergo regular screening mammography starting at the age of 45 years, which is a strong recommendation, and at the critical period from 45 to 54 years old, women should have an annual mammogram. Apart from this, women above 55 years old should have transition to biannual screening as long as they are overall healthy and the life expectancy is 10 years old. The American Cancer Society doesn't recommend clinical breast examination for breast cancer screening. So what has been changed comes more conservative starting the age of mammography. It comes 45, which brings the American Cancer Society recommendation closer to the guideline of the other advisory group, the USPSTF, which endorses biannual screening for women aged 50 to 75. The proposal for more frequent annual mammogram in the critical period from 45 to 54 years old. Another thing is a recommendation against routine screening by clinical breast examination, and recommendation to stop screening among the women with a life expectancy of less than 10 years old. And this is the recommendation published in 2009 of the other advisory group, almost the same as we mentioned. This animation video gives us a brief detail how we are doing the mammography. This is the mammography machine, and the X-ray tube is in the top, and the cassette downwards with a plate. The patient is viewed in two views: the craniocaudal view, with the breast is resting on the cassette, and the plastic plates make compression of the breast. I propose to make this video. Some clinical situation we cannot do mammography as the patient of recent post-operative suturing, post-operative status, acute mastitis, and extensive breast edema. It may be very painful for the patients. The other view is the midolateral oblique, the same, but with tilting of the machine. And then we get the mammographic view. What the clinician, what radiologists mainly focus on in mammography. In mammography, there is some certain criteria in the reporting of the mammography. Mainly there are two views, the routine view, the cranial caudal and midlateral oblique. The breast tissue is not normal along the female life. Glandular tissue becomes more prominent in the childbearing period and become scanty in the older patients. Any mammographic report should have a first status description of the parenchymal density and then specific lesion description and finally overall assessment of the management recommendation of the patient. First, we can describe the density of the breast ranging from the flaccid breast until the dense glandular tissue. Then we talk about the masses classification, ductal system, and skin and axillary lymph nodes. The masses we must describe the margin density and shape in patient orientation. Ranging from the fat-containing density, which is mainly benign, hamartoma, lipoma, intramammary lymph node, and fat necrosis. Just some example, lipoma. And this is like fibroadenoma, intramammary lymph node. Adjuvants is probably benign, ranging from the breast cyst to focal adenosis. And the high density is the probably malignant tumor, carcinoma and cystophylloid tumor, abscess, and the other criteria is a focal asymmetry. You can see focal asymmetry in mammography. Focal asymmetry is a very common presentation, and this patient is revealed to be a hypoechoic by ultrasound highly vascular lesion with grade 3 invasive ductal carcinoma. The wide range of pathology seen in focal asymmetry ranging from normal fibroglandular tissue up to carcinoma lymphoma. And digital mammography had preferential than the analog mammography in detecting lesion in dense breasts. The classification is also dedicated mammography for the classification of the calcification ranging from the benign, intermediate, and malignant, according to the morphology and distribution of the microcalcification. This is the types of benign calcification, oil cyst, skin calcification, egg-shaped calcification, and popcorn. All are benign types of calcification we encounter in daily life in mammography. And the suspicious microcalcification is unilateral polymorphic cluster having linear or segmental distribution and had to be biopsied by stereotactic. Also, the digital mammogram is superior than the analog in detection of microcalcification. That's why the microcalcification is biopsied by stereotactic technique. Here an example case of microcalcification cluster that had been biopsied and revealed and carcinoma inside. So, recommendation: the digital mammography is the machine of screening. The ductal system also can be assessed in mammography, like in ductal ataxia, where asymmetrical dilated ducts or solitary ducts may be found on mammography with the possibility of ductal carcinoma must be considered. We can do galactography examination for delineation of any underlying pathology. Skin thickening also, with a wide range of pathology causing skin thickenings ranging from inflammatory reaction, heart failure, renal failure, carcinoma, and inflammatory mastitis and inflammatory carcinoma all have the same appearance. In mammography, non-specific axilla also can be seen in mammography, ranging from non-specific axillary lymph nodes, lymphoma, and metastatic lymph nodes. So we talked about when to do screening mammography, and we talked about what you can see in mammography. Now we'll talk about some new updates in breast imaging, the 3D mammography, what we call tomosynthesis. It's the FDA-approved advanced technology of 3D imaging of the breast, where we can, the female will be imaged by new techniques where the breast is scanned in very thin slice, up to 1 millimeter, with the average same radiation dose as compared to the digital mammography. The same technique, but the difference is rotation of the machine as well as the cassette and in the time of imaging. This gives us a very thin slice thickness of the breast imaging. This make the detection of microcalcification or pathology and dense breast especially more easy. So this is the condensed breast tissue when imaged by 2D technique that can be easily scanned by 3D tomosynthesis. So you can see clearly layer by layer the breast pathology. And here is the real-time imaging, one example of tomosynthesis. So you can see the level of the glandular tissue all through. At the same time, it makes the same dose, better visualization, and this time will go time for the patients. Finally, the other things that we are happy to be close to have one machine of the automated ultrasound examination of the breast. This is a new dedicated breast ultrasound examination of the breast. A new ultrasound machine that's imaging the whole breast in 3D volume. We are close to have one of these machines in our National Cancer Institute, disposable cover and perfectly designed probe for ultrasound that can sweep all the breast from medial to lateral and take a lot of information. All the breast tissue can be imaged and reformatted in the software of the machine. So after that, this is a real-time imaging of the one patient. We can image all the pathology in the breast in one session. This differs from the normal ultrasound machine. The normal ultrasound machine is operator dependent. Many lesions could be missed, especially tiny lesions. Here is the normal ultrasound probe, and it scanned a thin slice or a thin range of tissue. But the new modality, it makes like multiple stacks of probes are stacked together, giving a bigger thickness for imaging and better view. The image can then seen in a workstation in three views: the coronal, sagittal, and axial views. This may give us a good delineation of any breast lesion and a better detection of lesions, especially in dense breast female. Here we can have the result, the image, as a volume of the breast that can be then seen in the three axial planes: axial, coronal, and sagittal. And this brings us to the end of the lecture. Thank you.
Thank you, Dr. Mustafa, for your lecture. Any questions? Yes?
Well, 20 years old is not recommended for mammography as screening. If the patient had any complaint, she will have to start by ultrasound. But if it is a high suspicious lesion ultrasound, then you can go for mammography. But for primary, the 20 years old female is not recommended to go for mammography as screening. But I said that the screening in the digital mammography is better than the analog in the screen.
More questions? Okay, thank you, Dr. Mustafa. Now we have Dr. Sherihan Wahid Garir. Her talk will be the role of MRI in interventional breast procedures.